Yeah, thanks, Len, and thanks everybody for having me today. Yeah, I stepped in at the last minute for Cameron, who had some unforeseeable events arise and had to back out. So he sends his apologies for not being able to be here today. Um, I work in the same lab as Cameron. We both work with Dr. Alexander Wyatt, who is based at the Vancouver Prostate Center in Vancouver, BC, which shares a close affiliation with the BC Cancer Health Institute and UBC as a whole for treatment. I've been in Alex's lab for 7 years now. I'm just in the final phases of finishing up my doctoral degree on the study of prostate cancer genomics, and specifically using something which I'll talk about today, circulating tumor DNA to sample minute amounts of DNA in the blood as an alternative to tissue biopsies, metastatic or diagnostic.
Thank you. So please proceed with your presentation.
Sure. We'll get started right away. Feel free to hop in at any point if you have questions. And we're good to go. Can everybody see these slides?
Yep.
Awesome.
If I can see them, everybody can see them.
Yes, and please feel free to jump in at any point. I'll kind of just go through it, and I'm open to any questions. So yeah, the topic of today is developing a personalized approach to treating men with prostate cancer. Personalized medicine and personalized oncology and personalized oncogenomics, these are all buzzwords that have been circulating around not just prostate cancer, but a myriad of cancers and non-cancerous diseases. The idea of tailoring a therapy or treatment regimen to the specific needs of a patient or the specific aspects of a tumor. So that's what we're talking about today and how that applies to prostate cancer specifically. As I said, I'm a PhD student at the University of British Columbia, and I've been with Dr. Wyatt in the graduate program since 2017, though I was working with him as a co-op student for a few years before that. And my particular focus is on computational aspects of the biology of cancer genomics. So some background. I know everybody here will have a pretty wide range of experiences or familiarities with this. So we're going to start at a pretty ground level and slowly build up from there. So cancer is frequently described as a genetic disease. And this is because this DNA present in the majority of cells in the body normally is present as almost like a book or a source of reading material for cells to understand how to go through the day-to-day processes they need for function. However, mutations can arise in the DNA. These are changes to otherwise the normal reading systems for the cells. These mutations can arise from a wide range of sources. Some are hereditary and are passed down through maternal or paternal lineages, and then these will be present in every cell in the body. Some arise via exposure to radiation, such as ultraviolet light, chemicals, such as carcinogens known to present in things like tobacco smoke. Even the day-to-day process of the cells, as pointed out by Frank earlier, that when cells divide, sometimes things go wrong and errors arise. Those can also lead to mutations. The vast majority of these are suppressed and controlled. The cell has a lot of redundant processes in it to fix DNA damage. But unfortunately, problems do sometimes stick around. And if enough of them pile up, you can get to this state where cells that are normally supposed to sit quietly and do their job are dividing or spreading or moving the things they should not be doing. And when it reaches a certain degree of proliferation, we term this cancer. It's important to delineate two major categories of mutations. And I think basically all mutations can be broken into these two categories, germline versus somatic. So germline mutations are inherited from either a mother or a father and predispose, and some of them can predispose to cancer. A well-known example are mutations in the BRCA1 or BRCA2 genes, which stand for breast cancer associated 1, the cancer in which they were first described. However, mutations in these genes that are germline can predispose to not just breast cancer, but ovarian and prostate as well. These are different from somatic mutations that are acquired during life. They're not present in every cell in the body, but they are only present in the specific cell in which they arose, and any downstream cells that arise due to cell division from that initial cell of origin, which means that they're largely isolated to the source in which they arose, or at least as if it present in a tumor and the tumor spreads, limited to that tumor alone. And because of this, somatic mutations are not going to be passed on to future children. They're not present in the egg or sperm cells that would be used to give rise to offspring. It's important to note that germline mutations are very important in prostate cancer. Specific mutations like mutations in BRCA2 are associated with a much higher risk of developing prostate cancer at some time in life. And then germline mutations, while they predispose to cancer, it's the somatic mutations that are acquired thereafter that can drive progression or resistance to different treatments. Other thing to note is that mutations are going to be very variable across cancer types, but even between patient to patients within a given type of cancer, say prostate cancer. And this realization, which has happened in the last few decades or so, has then given birth to the idea of personalized medicine. If every patient's tumor is unique in its own way, are there ways to tailor medications to best serve different patients as compared to giving a one-size-fits-all approach? And then the idea of personalized cancer therapy was born. So if there are, say, genomic markers indicative of how well a tumor will or will not respond to something, and you can profile the tumor molecularly and understand what those weaknesses are, you can then prescribe specific drugs that will exploit that tumor, or as a minimum, not be resisted by that tumor at first line of treatment. That's kind of the general gist of the talk today, is now using DNA mutations to inform on cancer care and tying into this concept of personalized medicine. So this is a very rough overview of the treatment landscape for metastatic prostate cancer. When prostate cancer is first diagnosed, it can either be localized to the prostate gland or potentially in a fraction of cases already metastatic at first diagnosis in the clinic. Metastatic prostate cancer basically across the board is treated with some form of ADT, androgen deprivation therapy. This can be surgical or chemical. And as Frank pointed out, in recent times is often combined with a different series of drugs like abiraterone that kind of bolster its effect. And it's important to note, sorry, I missed this. In cases where the prostate cancer is, the cancer is localized to the prostate, the one of the first mechanisms is surgical removal of the prostate, which can be done with curative intent. If the tumor has not spread outside the prostate, then the surgery will be successful in removing it and the tumor is removed. If it does metastasize or was metastasized at diagnosis, you can follow it with ADT. And then once the cancer progresses to a point where it is not really responding to the low levels of testosterone and its derivatives as a result of ADT, this is when you begin the series of treatments for what is termed metastatic castration-resistant or hormone-resistant prostate cancer. Abiraterone, enzalutamide, chemotherapy, and a bunch of other treatments are all options in this setting. And these are just a few of them there. Immunotherapy is also emerging as an option in prostate cancer with some potentially less efficacy than other cancers. But then there are also a long tail of other therapeutic options available for this disease setting. At this point, it's good to consider what is a biomarker. And that kind of feeds directly into the concept of personalized medicine. A biomarker is any kind of biological molecule, maybe protein, maybe DNA, found in blood, bodily fluids, or in tissues that can be used to inform on the treatment course of a disease. An example is PSA, which is useful for prostate cancer screening and diagnosis. PSA is a biomarker in that sense. Biomarkers are not specific to cancer. They can be across any disease. But ultimately, they help determine which therapy is best suited for a given case. Oh. Biomarkers, this I should say here, this is kind of a term I was asked to define for this talk today. Personalized oncogenomics. It's definitely a mouthful. It's not too hard, though, given that we've built up to personalized medicine. As we said, personalized medicine is using patient-specific biomarkers to optimize therapy selection, and that can be across any disease. So for personalized oncogenomics, we're looking at genomic-specific biomarkers to guide treatment of a tumor. So PSA is not going to be a genomic biomarker. That's a biological marker present in the blood, but recognition of a BRCA1 or BRCA2 germline mutation, that is a genomic biomarker that will suggest how the tumor may or may not respond to different therapy options. So where do we get these biomarkers? PSA is obtained from a blood draw, but genomic biomarkers require some source of DNA. Now, for a long time, the sole source of that DNA was going to be tissue in some capacity. Tissue can be available at a couple different time points. If the prostate is surgically removed, you can have tissue there. Additionally, any diagnostic biopsies done are also a source of tissue, though much smaller than the prostate itself. And in some cancers, though less so prostate cancer, you can also perform a biopsy of metastatic tissue later in disease. But all of these come with some problems. Diagnostic biopsy tissue, or the tissue from the prostatectomy, they may not reflect the later stages of disease. As the cancer goes through different waves of therapy, shrinks and then grows again, there's this pruning process by which cells that cannot handle the treatment being administered will die off, and then all that's left is the tumor cells that then emerge as resistant. And so over time, you see this evolution of the cancer, and 5 or 10 years down the road, it may no longer reflect the prostate cancer that was first diagnosed. It's acquired a host of somatic mutations that have changed how it will respond to different therapy. So looking at a piece of tissue from 10 years ago may not be very useful in selecting the treatment for today. Additionally, in prostate cancer, performing biopsies of metastases is not really routine. Prostate cancer has a tendency to spread predominantly to bones. And biopsying bones is very difficult. It requires specialized training in a surgery room as compared to just use of a blood draw, which can be performed anywhere. It's very expensive. It's very invasive and painful to have a biopsy performed of bones. It's just really not suitable for a lot of the cases that come through the hospital. Plasma cell-free DNA is sort of emerged in the last half a decade or so, as an alternative to using tissue as a source of DNA. It comes with a lot of great benefits straight out of the chute. For one, it's minimally invasive. Similar to taking a blood draw to look at PSA levels, you're looking at DNA that's simply floating in the bloodstream. So any vial of blood will suffice as a source of DNA, as long as we have a few mils to work with. And within that bloodstream, like I said, there are DNA fragments that have been shed from cells, both tumor and non-tumor, into the bloodstream, and we can extract that tumor DNA and look at it all from a single vial of blood. So really, right away, that's very beneficial. It can be done at any point, so it's useful to, even in the later stages of disease, when that early tissue is no longer representative, you can take another blood draw and get the most up-to-date snapshot, if you will, of what's going on in the tumor at that point. Additionally, DNA shed into the blood doesn't stay around very long. It's cleared by the body within a few hours at most. More DNA will constantly be shed by cells. What this means, though, is that when you take a vial of blood and extract the DNA and look at it, you're looking at a real-time update, DNA that was shed by tumors in the last few hours before that blood vial was taken. So it's very up to date, and that's very useful in keeping track of what therapies are best to use. Cell-free DNA represents all DNA shed by any cell into the bloodstream. And like I said, that can be tumor or can be non-tumor. What we do see is that in patients with cancer, there's an increased amount of cell-free DNA observed versus people without cancer. And it's important to differentiate a secondary term here. We talk about circulating tumor DNA, ctDNA. Now it's a little confusing, CF versus ctDNA. ctDNA, circulating tumor DNA, is simply the fraction of all DNA in the blood that comes from tumor cells. Now this can range from 0, undetectable, all the way up to 80% of the total cell-free DNA or more that we see. So ctDNA is the fraction of cell-free DNA from the tumor. And one thing we observe is that this fraction, the amount of tumor DNA that we extract, the amount of DNA that we extract that comes from the tumor versus other healthy cells, that correlates with the overall burden of the tumor across the body. So on the left of this diagram here, the best prognosis cases, maybe very early After diagnosis, a low proliferating tumor, no metastases by imaging, these cases are likely to have very little circulating tumor DNA that we can detect. All the cell-free DNA we pull out will just be from healthy cells. As you move into a worse state of prognosis, a tumor that is spread to a lot more regions, metastasized to bone or visceral organs, the tumor is highly proliferative and there's a lot of turnover of cells, these patients will be the ones that have the most amount of cell-free DNA that comes from the tumor, so the highest ctDNA fraction. Because of this, just the amount of ctDNA we measure kind of informs already on how that tumor is doing, but we'll get to that kind of point a little later. But the advantage of this is that this DNA present in the blood can be sequenced to look for specific genomic tumor mutations. And these serve as genomic biomarkers that we can then use to guide therapy selection. As we talked about before, we have this difference between germline and somatic mutations, inherited versus arising de novo. So what we do is we sequence both the germline DNA, so that's DNA that's just benign, there's no tumor in it, and then specifically the cell-free DNA component that contains both tumor and non-tumor to kind of get a view of both. If you sequence normal healthy cells, you'll understand what the germline state looks like, so any inherited mutations. And then you sequence what's shown in yellow here, the plasma cell-free DNA, to try and pick up mutations specific to the tumor that are circulating in the bloodstream. One thing we're often asked is, are we confident in cell-free DNA? How reliable is it? Does it hold up to what is considered the gold standard, which is analysis of tumor tissue? So this is a bit of an older study now, but is one of our first in a series of concordant studies that compares sequencing of DNA from tumor versus cell-free DNA. So in this figure here, all you're simply looking at is on the top, each bar represents a mutation captured from tumor. And on the bottom represents the same mutation captured in the liquid biopsy, the cell-free DNA from a blood draw. And what you largely see, though there is some difference in height, every single mutation observed in the top is also captured to some degree on the bottom. The frequency, the amount of times we see it is variable, but largely we always capture the same mutations again. This is a very good proof that the cell-free DNA profile is concordant. It matches what we observe from a solid tissue. So going into more specifics, what kind of information can we learn from circulating tumor DNA? This is a good point to kind of come back to the idea of biomarkers for a sec. Biomarkers can offer a wide range of information, and there's a difference between markers that are prognostic and markers that are predictive. So a prognostic marker gives an overall impression of disease aggression regardless of treatment type. So PSA level, for example, is rising PSA is prognostic of a rising tumor burden, and high PSA can indicate a larger tumor spread. Predictive biomarkers offer specific knowledge on tumor vulnerability or resistance. So in this sense, PSA can also be a predictive biomarker too. If you see PSA rising while on treatment, that may be indicative that the tumor is now resistant to that therapy and is starting to spread again. Some markers, though, are only prognostic or only predictive. It's more about what kind of information you're getting from the marker you're looking at, and they can all be used in different ways. So what I talked about ctDNA and the kind of the levels of tumor-derived circulating DNA as a prognostic marker of the overall disease burden, because in the patients with the best prognosis, earliest in stage, we don't see much ctDNA, but the ctDNA levels are much higher in the later stages, more proliferative disease. That in of itself suggests that ctDNA quantity, ctDNA abundance, is in and of itself a prognostic marker. So you're looking at here are these what we call Kaplan Meier survival analyses, and kind of gives an impression in these groups that are subgrouped based on fraction of ctDNA. So in gray, there is no ctDNA detected. In the pink middle line, you have low levels of ctDNA, and in the dark red here is the highest levels of ctDNA. And these numbers here, 30 to 100%, is the fraction of all the DNA in the blood that we observe is derived from the tumor and not from healthy cells. And the general impression here is that this gray line, the cases where there was no ctDNA detected, have by far the longest durable survival compared to cases with low or high amounts of ctDNA detected. And this has been recapitulated across multiple studies here. These two plots left and right are showing the same thing, just in different cohorts, with the one on the right being even more stark across the 36 months measured. 0 patients with no detectable ctDNA died while undergoing review. Beyond that, looking at ctDNA levels over time can also assess response to therapy, kind of in the way rising PSA can be analogous of resistance to therapy. And so these two plots here, each vertical line that corresponds with a different node, these are different samples taken throughout treatment. And then the horizontal lines are the levels of ctDNA. And what you're looking here on the left is this steadily increasing line, slowly but going up, observing that the ctDNA levels, the fraction of tumor DNA increases at each collection. And this is a patient that did not respond to the therapy they were on. In contrast, on the right, you see that dot starts very high and then immediately crashes to 0 at the second line. This is where the ctDNA levels dropped from high to undetectable after the start of therapy, and this patient was observed to have a dramatic response to the therapy they were on. And just a way to think about that, the more tumor in the body, the more DNA being shed. If the tumor is rapidly disappearing due to a very effective therapy, there will just be less DNA to detect overall. This is also useful. Something we were talking about before is that in the later stages of disease management, PSA may no longer be the most reliable marker as the tumor becomes a bit divorced from the prostate-specific antigen, but ctDNA may be a marker to study disease progression even after PSA is no longer effective. One more example of ctDNA as a prognostic marker is looking at mutations in genes like p53. So p53 across all, I'll say across all cancers, across the vast majority of cancers is a frequently mutated gene, so much so that it's known as the guardian of the genome and is one of the first things lost in many cases of cancer initiation. And in prostate cancer, we see it's lost in the later stages of prostate cancer in about 50% of cases. So it holds for prostate cancer as well. On the right here, you're looking at another one of these survival plots. And now we have an additional component we've added in. The gray line is still the best cases, the cases where there was no ctDNA detected. In blue, pink, and red, we're now looking at the cases with ctDNA and whether or not we detected a mutation in p53. Blue is no, pink is yes, a single one, and red is 2 hits to p53, 2 mutations. And each of these corresponds with a worse overall prognosis due to the fact that loss of p53 is prognostic of aggressive disease that's going to respond more poorly to therapy. Again, this is not predictive. We can't know how the tumor will respond to a given therapy specifically, abiraterone versus enzalutamide versus olaparib, for example, but more just a general sense that if the tumor has detectable levels of ctDNA, if it has p53 mutations, overall it will respond more poorly and progress more rapidly than a tumor without those qualities. That's prognostic. On the alternative, mutations can be predictive when detected in ctDNA. And an example here, and this is from some of Cameron's work, mutations in the gene AKT can predict response to a specific type of therapy. This figure on the right here is pretty complicated, but what essentially you're getting at is it's multiple different areas of this is a bladder cancer actually, that was analyzed and looking at all different regions of the tumor and whether or not each different region did or did not have the AKT mutation of interest. So again, in the top right of this little pie chart, Events in green indicate the presence of AKT mutations across different regions. We saw this in cell-free DNA, also able to see this in the archival tissue that provided the picture here. My apologies. No, this is a prostate tumor. This is not bladder. My mistake. Sorry. There is they sampled of the bladder and neck, but this is a prostate tumor. This is kind of a zoomed out version, looking at the pelvis as a whole. This AKT mutation. Sorry, did I hear something?
Yeah. Sorry, just before you go on, I've seen in a couple of slides the term visceral, I think it was metastases. Does that mean to specific organs, including bone, or could you define that?
Yeah, for sure. Definitely not an area I'm an expert in. That's much more a clinical area, but largely, and as I understand it, it will not include bony metastasis. Viscera and visceral metastases are to specific regions around organs or visceral organs, like liver metastases, as compared to metastases to bone tissue, which are going to be separate from visceral. And that's often a simple demarcation on basically bone or not bone that is applied to a given metastases.
So they've either it's been a resection or they've sampled a metastases.
Yes.
And this is not. Okay, thank you.
Yeah, exactly. Visceral metastases are sometimes easier to sample than bone metastases for reasons. It's just harder to get inside the bone. But yes, exactly. You are correct.
Thank you very much.
No worries. That's a good question. Yeah, this is now a zoomed out version. I'm looking at the pelvis as a whole, and both the prostate and then multiple different lymph nodes around the prostate were sampled. And again, we see this AKT mutation present across multiple different regions. This is a mutation that is kind of central to the tumor development and is present in every single sample that we were able to observe, including this blood drop at the top here that was present in the cell-free DNA as well. So as far as we can see, AKT mutation is present in all cases, or in all samples within this case. And this corresponds to a quite dramatic response to an AKT inhibitor. So this is a drug that specifically exploits a tumor that does not have or has an AKT mutation. And so this is the overall course of treatment. You can see many of the common names popping up: docetaxel, enzalutamide, etc. And then in this late stage here, just before around month 40, where the patient was no longer responding to most standard of care therapies, was given an AKT inhibitor, kind of seen as a last resort, because this was a little earlier in the understanding of this. But because there was an AKT mutation, there was a very dramatic response for about 8 months to this drug, ipatasertib, which is an AKT inhibitor. So this is an example of identification of the AKT mutation in the DNA was predictive of response to this, target-specific inhibitor drug. Any questions on this? This is kind of a lot of different concepts coming together here, so I can give you a moment to just digest this.
Well, it seems to suggest that there are certain cells that are more susceptible to mutation than others.
Yep, that is true. I think I know what you're getting at. Yep.
I have a question, Evan.
Yes.
In looking at this slide, at what point was the was it noted that there was a mutation to the AKT1 gene and the drug therapy was then changed? I can't see it. I can't.
That is. Yeah, I do not think it's annotated. I believe it would have been at the point between 36 and 42 months at that peak prior to administering the drug.
Then
Once they know,
yeah.
So this is an example of.
Thank you.
You're welcome. An even more dramatic case, and one I have shared in the past actually, because it's a case I was involved in personally, and kind of one of my first experiences is how incredible biomarker-driven therapy can be, is this case here. So this is a patient that had deletion of the gene BRCA2. It's not just a mutation that messed with its structure. This is a full deletion that removed the gene from activation. And there were 2 of them, not just one, but 2 deletions that removed any copy of BRCA2 from the tumor cells. Now, BRCA2 is a tumor suppressor gene, and without it, you tend to have a very aggressive cancer that can acquire a lot of mutations very quickly. And kind of getting with what Len said, cells that don't have BRCA2 are much more likely to acquire mutations than cells with BRCA2 intact. So this is a patient that had progressed on every standard of line therapy and had a lot of growing tumors across the pelvic region and metastases, a lot of burden. They'd also progressed to a state of what's known as neuroendocrine prostate cancer. It's a small cell subtype that, long and short, is very aggressive and has poor response to the vast majority of treatments available. But recognition of the BRCA2 deletion informed a decision to use something known as platinum chemotherapy, which has been around forever and is not an expensive drug. It's not some $100,000 a year kind of therapy. Carboplatin or cisplatin, these are standard drugs, but they're not used very often in prostate cancer in favor of overdose Taxol. But it's known that they have a specific remarkable capacity to tackle tumors that are deficient in DNA damage, and BRCA2 being a classic case of inability to repair DNA. And when treated with cisplatin, experienced an incredibly dramatic and long-term response to this therapy due to the fact that they could not repair DNA. And this was a durable response that continued long after any expected survival, given the state of the disease prior to treatment. It really was a dramatic case. And this patient continued to do very well for years throughout the first part of my PhD on this therapy. And it was a really inspiring case to see.
Yeah.
So kind of bringing that back, I guess I've seen a couple cases here. The real takeaways is that CTNA, the fraction of cell-free DNA from the tumor, can be used to inform different optimal treatments for different tumors, depending on the given set of mutations that they've accrued over time. But all of this work is correlative. And to change clinical practice, you need what are known as prospective trials. So retrospective is when you go back and look at old stuff and try and find new data in there. Prospective is a clinical trial that's designed to specifically test this feature. So this is a trial that's been going on for a long time, led by Kim Chi at the BC Cancer Institute, who works closely with my PI, Dr. Alex Wyatt. But the idea being is that when enrolled, a cell-free DNA sample is taken, the tumor genomics are analyzed prospectively so that patients can be put onto different arms of the trial, with the purpose of giving them optimal medications are best suited for the given mutations present in that tumor. So for example, you'll see down here, the case in orange, PIK3CA or AKT mutations, which you talked about earlier, those patients will be prioritized for an AKT inhibitor, which is not going to work in the vast majority of patients that don't have one of those mutations. And then there's a long line of different mutations different treatments that can be applied to different mutations.
Wow.
Another example in the dark blue here, specific AR mutations. As mentioned, abiraterone is emerging as a very frontline therapy to use in prostate cancer, but mutations can arise that render the tumor resistant to abiraterone. Darolutamide is what's known as a third generation antagonist of the androgen signaling pathway, and continues to work even after abiraterone and enzalutamide have failed due to specific mutations. So this is a subset that even if there's no unique event, an AKT or a BRCA2 event that's emerged, even a resistance mutation here can inform on which drug to give next. In the case of these specific AR mutations, darolutamide is a great option to go, and you can still get some more efficacy out of that treatment option. Kind of wrapping up here into the last part and understanding CTNA from a slightly different angle, the idea of heterogeneity or variation, essentially, across a given tumor. So one thing that's emerging as a realization in the field is that because CTNA the DNA in the blood, is comprised of DNA from cells all across the body, it theoretically represents a host of different tumor sites, both the origin site and the metastases, because all of them could be shedding DNA to some degree. All of that can be sampled in a single blood draw. So one area of work that our lab is working on, this is moving a little away from the clinical into more the biological, trying to understand this on a genomic level. Can we use CTNA to characterize the genetic diversity across tumors? Now, people might ask, why is this important? But this heterogeneity can predispose poor response to treatments otherwise you might think effective. For example, in this figure here, if the pink and gold clones here were the only ones sampled, and you observed that they had say a BRCA1 mutation, that's great. That might mean response to a certain therapy. But if blue and green have evolved an additional mechanism, or maybe don't have the same event, such that they won't respond to therapy, now you're giving a therapy that only half the tumor is going to respond to, and other half of it is already resistant or will not respond. So maybe that is not the optimal choice. And this kind of concept is only more recently been appreciated, that even within a single tumor, different sites can evolve to be very different from each other. So we're trying to understand this interplay to better optimize, just better understand how this could translate into the clinical setting. So on our end, this, when you sample this DNA, you bring a host of different stuff into analysis. These concepts of subclonality, different layers of tumor within the single blood sample. So it's beyond the ability of any of us to interpret on our own. So we're trying to develop computational algorithms to understand how many tumor populations are present within the cell. The better we understand this, the more this can translate to meaningful treatment in the clinical setting. And kind of that's what this graphic here on the right shows. Within a single blood sample, you might have DNA from four or more different sites around the body, but they're corresponding to four distinct states of evolution within the tumor, some potentially very diverse from each other. Prostate cancer stands out among cancers as being definitely one of the more genomic and molecular heterogeneous, higher levels of variability than many other cancers, which are sometimes driven by a very aggressive but very monoclonal, very singular focus line of evolution. Kind of coming to the end here, though, of the talk, the real main takeaways from this is that, as we said at the beginning, cancer can be driven by mutations detected in the blood via this tumor component of cell-free DNA that we call circulating tumor DNA. Simply the level of tumor DNA in the blood and certain mutations detected are prognostic. Higher levels of tumor DNA are bad, low levels are good, just with regards to any therapy that you might administer. But specific events like AKT or BRCA2 mutations may suggest a therapeutic vulnerability that a drug might perform better than expected when compared to the average response across patients that don't we haven't identified this specific marker. I think that brings me to the end. Obviously, I can't do even a fraction of this work alone. There's a huge team of people behind me doing a ton of work. Thanks to them, thanks to the many doctors involved in this. But of course, above and all else, thank you to the patients and their families who continue to support and help this ongoing research. Thank you.
Thank you. Hey, questions?
Okay. Yeah.
Hi.
Yes.
Your question.
Speaking to the heterogeneity, so so when you're getting your liquid biopsy results, is it kind of more of a soup, so you don't know where specifically it's coming from, or do certain tumor sites tend to yield distinctive characteristics, so you can say, oh, that's probably the liver, or that's probably the bone, and does bone yield the liquid as well, easily or not, depending on?
That's a really good question. So the simple answer is it's mostly a soup in many ways. In theory, most of the cells obviously carry distinct hallmarks of prostate cells relative to other cells. In theory, to spread to the liver versus the bone versus the lung, for example, there are specific characteristics that must be acquired in order to survive in those different environments. Pulling those out of tumor DNA is difficult. And I would say on average, you can't tell from which region different DNA arose. That is usually quite hard to establish. It's more just a general snapshot of every metastasis in the body that is shedding DNA. And important to note, sometimes different regions may be shedding a lot of DNA. And so the signal that we observe from them is very high. Sometimes for whatever reasons, the levels of DNA being shed from a given region are very low. So it's not an even snapshot either. Different sites at different times may correspond less or more to the overall picture that we see.
And if you start out with a more aggressive grade or score or whatever type of prostate cancer, is the likelihood that you more likely have some of these aberrations higher, I'm guessing. But if the tissue available, aside from liquid, sorry, that's your topic, but aside from liquid, am I understanding correctly that the biopsy and the resection samples are kind of like water under the bridge? So you can't go back and look at any other markers than one or whatever we have reported already?
Yeah, great question. So yes and no. If, for example, the DNA in someone has never been studied and they've kind of gone on the standard line of ADT surgery, ADT, abiraterone, for example. And then as you're moving to late stage disease, we're wondering if, okay, is there a specific therapy we used and we know nothing about the tumor? The archival tissue will still inform on, say, germline events, like the BRCA1 and the BRCA2 that are inherited. Those will still be present in the archival tissue from the diagnostic biopsy or the surgery performed. So that's still informative. And maybe the initial mutations that gave rise to metastasis, those are present in the initial surgery. The things that won't be present, like the example I gave with that drug darolutamide, which can be used in cases where a specific mutation that gives resistance to abiraterone has arisen in the metastatic setting, that kind of late stage stuff might not be present in the tumor if the tumor was removed before abiraterone has even been administered, for example. So there is still knowledge. I'm definitely not saying that tissue is useless by any means. It can still inform a ton of stuff. It's just the fine tuning, the nuance might be lost, and more information will no longer be relevant as you move from years to maybe a decade post-surgery.
And are those samples kept somewhere if it hasn't been done at the cancer agency?
Yeah, I mean, I can only speak to my center. Different centers or different countries will have different processes. I know that every patient that comes through the VPC and the BC Cancer, all of those initial, not just biopsies, but also the prostatectomies performed, the tumor is, when the whole tumor is removed, those are all saved and biobanks. And the team I'm part of is building something known as the GU Biobank, genitourinary cancer biobank of not just prostate, but bladder, testicular, and so on, that now has thousands of samples in it. I know some of our colleagues in Belgium have commented that by law, once tumor is extracted, they are not allowed to destroy it for up to 30 years after its extraction. That was a fact that was dropped in a recent meeting. I'm not sure how long it is for Canada, but I imagine it's of a similar duration, that the tissue must be kept and stored before anything can be done with it.
Okay, thank you.
Do you get permission from the patients to use
Yes.
tissues?
So, yep. So definitely we can't do anything without patient consent. I know for the GU Biobank, so that's Vancouver Prostate Center, BC Cancer specific, when patients are, say, at first diagnosis or undergoing lines of therapy, they can consent to joining the GU Biobank, and their tumor that's removed or any blood samples taken from then on are consented to have very specific types of research reported. And if we want to change that, then we go back with a new proposal to amend the process. But yes, the ethics committee and many others demand that all that is done upfront first before any work can be done. With, I think, the exception of tumor that's been banked from patients that passed away many years ago, there is a degree of okay, well, that is no longer helpful, but if you're going to use it for a research purposes, maybe we can explore that, something we can do with that. But I'm also not an expert on the specific ethical consent legalities around that, something that my mentor and Dr. Kimchi would be dealing with on a much more daily basis.
Thank you.
Norm?
Yes. Evan, how common is the use of personal oncogenomics in the treatment of metastatic cancer here in Vancouver at BC Cancer?
Great question. So the umbrella trial is that I mentioned on the this one is an ongoing one that's kind of gaining speed and going on for a few years now. So it defines. It's a different question. I would say the vast majority of patients coming through right now are attempted to be enrolled into this arm to optimize treatment. That's a different question than how many patients fall under one of the actionable lines of therapy versus those that we can't find a biomarker and then have to go to more standardized lines. Those are two different questions. I would say for the first, as many patients as possible are we attempt to screen for some sort of biomarker to personalize medicine. I know the Genome Science Center has something called POG that you may have heard of, the Personalized Oncogenomics Group or Oncology Group, and they attempt to do a similar thing where they extract DNA and it's reviewed by a board of specialists to optimize the best medication, not even like a standard list, but they often give this case where they were able to find a blood pressure medication that through some unique interaction was actually able to depress tumor development when something that nobody else would have ever thought to use. So those are very different cases. To answer the second question, what fraction of cases do we see come in have something that can then be personalized versus those that can't see anything? Pretty hard to say question because we're emerging new biomarkers. If you look at BRCA2 alone, for example, it's kind of been an area of my focus. These DNA damage repair genes like BRCA1 and 2, while pretty rare in the localized prostate cancer setting, the more early stage, it's about 2%. You see them enriched in the later stage, the castration resistant, across DNA damage repair genes, up to 10 to 20% of cases may have one or more of these repair mutations. That's not saying they will respond as well to the one case I showed, but that's just a fraction of, that's just one arm of these arms. So you're looking at a decent proportion of patients that at least have something that can be tried, and new biomarkers are emerging all the time. So
a follow-up question, Evan. What stage of cancer would a person have to have in order to be eligible to go into this area, this trial?
This trial is only for metastatic castrate-resistant prostate cancer post-treatment with Abienza and or docetaxel, I believe.
So those would have to have failed.
Yep. So this is all late-stage stuff. Prior to that, the initial lines of surgery, ADT, Abienza, are still so efficacious that you would not use this more experimental stuff without trying those standard things first. Yeah, and with the occasion of a few like great stories that pop out, even a drug, say like the platinum chemotherapy that works really well in the BRCA1/2 cases, the vast majority of time, like it will still work, but it's not going to be, you know, an amazing curative response. And first line Abienza is still a strong way to go right now.
Any other questions?
Evan, could you say a little bit more about the tumor review board that you show in that slide on the umbrella trial? Who sits on it and what function do they play?
Yeah, for sure. So I will forward, that's definitely not something I know about, and I'm not on it as a student. That's specifically a board of PIs, like my PI, I believe, but mostly clinicians. So either GU oncologists, radiation oncologists, or pathologists who can review the data and then best inform on who to go next. So it's a combination of genomic specialists and clinical specialists.
Richard, you had a question?
Yes. Evan, this was a lovely talk. I have a somewhat complicated question. I don't want to lose the whole audience here, but let me throw in a couple of things. One of the things that you just hinted at the end, which I think is an intriguing area, and I know from hearing Kimchi talk about this about a month ago, is to not just look at the mutations, but look at the sort of the mutational pathway. That is what comes first, what comes next, if you have this mutation, what's the likelihood of showing next that mutation? So is that correct? I mean, that's one of the new things you guys are looking at. One of the things as I listen to these questions, a lot of people saying, and I think there's been, as I've been at Lynn Gross's support groups over these years, a lot of interest in the patients about genetic screening. And please correct me if I'm wrong about this, but I think one of the things you sort of didn't point out is that, and again, correct me if the number is wrong here, somewhere around 70 different little mutations can be, in some ways, in a modest way, prognostic, but not predictive. Yet, is that correct? I mean, is that about the number? I mean, I think from an old talk I heard Alex give about 5 years ago.
Yeah, that number 70, 73, I think is the
Okay,
exact number. That will refer to our team's specific panel that we've established. I would not say that it ends there. Those are just the 73 events that we would find as the most.
Right.
But there is a long tail beyond that.
So an important, and I think I'm summarizing this, an important point that Kim Chi made in the talk I recently heard that you didn't bring up is that just running off and getting that whole screen isn't going to help, because not all of those mutations show up in every tumor. And in fact, what I heard from Kim Chi, which I thought was intriguing, is there's a huge amount of those genes floating around in the circulating DNA that are not necessarily showing up in the primary tumors. And in that sense, just to go off and get everything screened is not going to be necessarily ready for prime time. So I think a patient's not to understand that just screening for everything doesn't help us know the pathway for which leading to the most aggressive tumor profile at that particular time. Is that fair to say?
Yeah, yes, a couple of things for the audience. The idea of the pathways that Richard's talking about. Like we talk about these genes in individualness, BRCA2, AK2, AKT1, but they're part of larger constructs that do a very specific purpose. So like BRCA1 and 2 are a few of many genes that repair DNA. When DNA is damaged, they fix it. In comparison, p53 is evolved in the cell cycle pathway. So when cells want to divide, p53 is one of the genes that says, no, you can't divide, something's wrong. And when p53 is then turned off, cells can divide as much as they want without being limited. That's a simplification, but those are the large pathways that Richard's referring to. And then kind of going into that second point that like, is screening going to be effective in all cases? And potentially, is that going to, inform on everything? Yeah, the answer is, I would say it's not that simple, particularly at the first setting when you're in really early disease. A lot of these events are very rare. The kind of area that we study is the latest stage of prostate cancer, when these really aggressive events appear much more frequent, but are present in a few percent at most of cases in localized cancer. And even if they're there in the early tumor, again, because the levels of DNA in the blood are so dependent on how much burden the tumor is, a small localized tumor in the prostate, maybe 1 or 2 mets at most, with still a slow turnover, is not even going to provide enough DNA for us to detect the event, even if it's actually there. So this degree of signal above the noise is also an important consideration for early stage.
Perfect. Okay, all of that was a setup for my actual question.
Okay.
All right. So, what I didn't get a chance to, I mean, when I heard Kim Chi talk a month ago, it was a huge setting, and there wasn't a chance to raise this. And it was actually more along the lines of what you guys are doing and what Alex's whole lab is doing. Is that I'm intrigued about the stuff that is prognostic, floating around, not present and dominant within the primary aggressive major tumors. And it occurred to me that rather than saying, oh, well, that's not a particularly relevant gene here, that's not another particular relevant gene, it does occur to me that another thing that may be going on is that these are, in fact, micro tumors that are being knocked down by the body's own defensive system. And that, in fact, instead of saying, oh, those aren't the ones that are relevant here, maybe, in fact, going after them, this is quite reverse of what you guys, I think, are thinking, or maybe you've already talked about this, that if you're, let's use a simple one, P10, right? Mm-hmm. So you get a lot of P10. You always do get a lot of P10, and you don't see it as badly showing up in the tumor. And you say, well, that isn't the issue. But where did that P10 come from? Was it in the primary tumor in the gland, and or was it in micromets all over the place and somehow was knocked back? Is anybody looking at it that way? That's my question. You can say wow and say we should talk about it offline if you'd like.
I can give 2 points. I think I'll comment on that. Definitely is something that should be looked at more. With regards to microtumors specifically being knocked down by the immune system.
I didn't say immune system. I wasn't going to go that far.
Or being suppressed by
whatever.
treatment.
Yeah, we don't know.
Yeah. Okay, so a couple interesting things. Things that are present not in the primary, but might be present in the micromets. That's very interesting. That can inform on bridging that gap. Even leaving the primary prostate is difficult for a tumor, so that has to be taken into account. One thing that's I think emerged as a really interesting case is these events. Maybe P10, but P10 is still really great example. Let's pick like a really random mutation that like nobody's ever heard before. Is on the panel, but it's not really well understood. We just see it frequently. What is the role of that? If we don't know a pathway it's part of, what is it contributing? Some really great data that's been talked about in more broad concepts of cancer evolution. And if you see this mutation in this gene, we'll call it gene alpha, and it's present at a high frequency, and you have no idea what it's doing, it doesn't seem to play a role that makes sense for tumor progression, it might actually be a flag of something else that caused that tumor cell to do really well. And this mutation just kind of happened to come along as a byproduct. If you'll allow analogy, if there's certain paint color of car had become really predominant on the streets, and you're like, oh, maybe that paint color is really popular, people want it for a reason, but it actually turns out no, this particular company made a vast majority of their colors in this vast majority of their cars in the color red. But the actual reason the car is so popular is because the engine is optimized. Nobody sees the engine under the hood. They just see the red cars in predominant. Maybe this mutation is floating around is indicative of some other process that's not at the genetic level, might be at the transcriptome, might be at the protein level, that's actually driving proliferation. But the mutation we see is just kind of like riding the wave of that. So it's indicative of the most aggressive cells, but is not itself informative on what the mechanism is. So that's a concept that's emerged in the whole dialogue around cancer evolution. I don't know if it really gets at what I talk about with the microtumors. That's definitely not an area that I know much about. We can also continue the conversation further offline if you want. Is Rich still in the talk, or he might have dropped out?
No,
I love it. That's a great metaphor.
Okay.
It's a great metaphor, and I look forward to you applying that same analysis to 72 other genes.
Thank you. Yeah.
Anybody else have a question? I have one for you, Evan.
Mm-hmm.
I think you were doing some work in Belgium, I believe, on tumors, yep, as opposed to liquid biopsies.
Yes.
And what you seem to suggest in your message today is that the liquid biopsies are just as good as the actual tumor.
Sort of. I think it depends on disease setting. So this is true. I went to Belgium for work with a team, and background in 30 words or less. We are looking at this subset of tumors that are metastatic at first diagnosis. First time into the clinic, the tumor is already spread. Even though that represents, 1 in 10, 1 in 15 patients, though it represents the vast majority of prostate cancer related deaths. It's just a tumor that's already very aggressive at the first state, not a good indication down the road. So we're looking at that. And what we've noticed is that in that setting, it's still fairly early in disease. So even though it's a very aggressive cancer, the ctDNA in circulation is non-existent. So we're forced to rely on tumor material such as we can obtain it in the absence of the liquid biopsy that is so effective in the latest stages of disease. So it's very setting disease dependent. And interestingly, August, on that note, prostate cancer is pretty good for CTNA. Some cancers have no tumor DNA or like no circulating tumor DNA for reasons we don't really know. But they're known as CTNA hot or CTNA cold tumors sometimes. Prostate cancer, we're lucky that it's effective, but not so much across the board.
Wow. Oh, thank you. Norm, you have a question? You're muted, by the way, Norm.
I can't ask my question unless I give myself a voice. A two-part question from kindergarten. Right at the beginning, Evan, you said that you're finding DNA that has been shed from cells. The first part of my question is, why are the cells shedding the DNA? And second part, do cancer cells shed DNA differently from healthy cells?
Yeah, excellent questions. The first one I can get at, that's pretty straightforward. So cells shed DNA, the main mechanism is that when cells die, which is inevitable for all cells that haven't somehow become messed with by the tumor, when the cell dies, it undergoes something called apoptosis. And this is cell death, but it's controlled, it's programmed. The cell goes through this as part of an experience. There's a very mechanistic breakdown of the cell. And one of the parts of that is taking the long fragments of DNA, chopping them up into little bits and kind of just vomiting them into the bloodstream. It's all very controlled. Different than necrosis, which is when cells die, not of their own volition. But however the cells die, by the necrosis, apoptosis, or some other mechanism, the contents of the cell are dumped into the blood, and that includes all the DNA that's been broken up, like a long stream that's been attached with scissors, basically. That's what we're looking at. So tumor cells do that as well. Tumor cells undergo apoptosis. There are differences in tumor DNA shed versus regular cells. And it gets pretty technical and over my head very fast. But an example is that the exact length of the tiny bits of DNA in the blood can differ, whether it's from a tumor DNA or whether it's from a tumor cell or a benign cell. And what we call these, measuring of the fragmentome is a word that's been circulated a lot. People love putting ohm on the end of everything, but the fragmentome is the collection of sizes of DNA, and that can, in theory, be mapped back to tumor specific versus healthy cells with some degree of efficacy. It's definitely not revolutionized the field, but it has emerged as a concept that even as a conference I was down in New Orleans is still being discussed and optimized as a way. And one of the biggest advantages of that is that when you take all the DNA from the blood, if it's say not a very late stage tumor, 95% of it might be from healthy cells. Is there a way to enrich for the very specific DNA bits from the tumor such that you can actually then look at the mutations, the biomarker possible events that are useful when you might not be able to detect them otherwise in such a drowned out noise from the regular cells?
Okay, good. Thank you.
You're welcome.
Frank, you have a question.
I guess a follow-on to that would be, are the fragments of normal cells longer or shorter than the cancer cells that you would find in this new area?
They are.
Seems like a simple test.
It is, but the difference is very minute. So DNA is millions of bases long.
Statistical number that you would be looking for then, and not a, we see short ones. This is
no, it's so DNA. So the DNA fragments in the blood have a very specific size. Often, 167 base pairs is a number that's thrown out by the specialists. And what this corresponds to, and we're getting really into the nitty gritties of cellular biology, but essentially when DNA is stored, it's wrapped around histones, like a thread around a ball of yarn. It's wrapped around each one, and this coils DNA and keeps it protected. And it requires an uncoiling of DNA before anything can be done with it. And the size of DNA is basically exactly proportional to the ends of the DNA on both sides of the ball. So it takes 167 base pairs to go all the way around. And so when it breaks here and it breaks here, the fragment of DNA is thus the circumference of the ball in exact size. Now that differs very slightly in cancer cells versus normal cells. And I'm not going to throw out any specific higher or lower numbers. I know it's much more complicated than that. It's more patterns of how many molecules are between before the cell is clipped. So it's not so big, and the differences are very minute. I'm sorry I can't give a more specific
Probably answer. Smaller, I would think, because of the healthy ones, 160, about 160, 170, and a defective one's probably going to be less, but
potentially.
Who knows?
It's so simple. Any other questions? So one more question, Evan. Could there be more than one mutation in a cell?
Definitely, yes.
Wow.
Yep. Well, yes. I'll actually let me rephrase that. More than one mutation that's meaningful, that's actionable. Yes, often. There are many mutations that are accrued in the range of hundreds potentially. The vast majority of those are going to fall in either not even in a gene, just in the empty space between genes. And though for the extreme end of the computational nerds that has some interest, by and large, it's not going to have an immediate clinical effect. They might fall in a gene that's not going to do anything relevant to cancer, or there'll be a very, very small subset that fall in a gene that is relevant to cancer. You can still have multiple of those in a patient or in a tumor. Are you going to have multiple that are also actionable? We're getting into subsets of subsets of subsets here, so you're less and less likely. But yes, the answer is it's entirely possible. There's no biological reason why you couldn't.
Remember, Len, remember the zipper that's like 5,000 miles long?
Yeah.
That's why all the information is there. So
It gets a few
you're bound to
kinks
get more than one mistake.
I just think that this makes it so easy to understand. This is so complicated. I just admire you guys for this kind of research. Wow.
Thank
Well,
you.
over the last 10 years, it's just amazing how in-depth and at such a like nanoparticle level they're able to figure out this stuff. Because remember that we're used to 10 years ago where you either had like a Gleason 4 or 5, and that was based on, gee, the shape of the cells, and that was what everything was based on.
Yeah.
Yep.
Now people know what's inside.
My gosh. I mean, it's thank you, Evan. It's been so revealing.
Thank you.
Any other questions anybody has? And anyway, another question.
Sorry if I'm taking up too many, or if
I'm
this
sorry, you're not Peter though.
No, I'm Peter's wife.
You have a name?
Kathy.
Kathy. Thank you, Kathy.
So we're kind of new to this, so I'm sorry if I'm a little off topic or if this isn't appropriate, but just only getting information or absorbing it slowly. But one question is, if there is perineural invasion on the pathology of the tumor, do you happen to know or be able to tell us, biologically speaking, what the typical thing is for that? Like, we think of the nerve as slow growing. So is it going to tiptoe along the nerve path, or is it going to be prone to plopping out here and there? And is that representative of much of the late stage stuff that you see, or are you able to tell? Or maybe this is off topic. I don't know.
Well, it's a fascinating question. And I can definitely say that sadly, I haven't the faintest idea. Perineural invasion is something maybe Frank can speak better. I've never read very much about that at all.
Yeah, that's not so significant on a report. So that's not something that would typically be found if you looked hard enough, I think, in most cases.
Sorry, I couldn't hear you.
Well, you would typically find that in most cases after a prostatectomy.
Oh, I see.
So, Richard's got a second opinion. So here you can get a second opinion from two non-medical doctors.
Okay.
Am I supposed to speak?
Well, you're shaking your head, Richard, so maybe you've read a different paper.
Perineural invasion simply means that the tumor in the gland was right near the edge and poked through. The nerves run on the surface. Oh, by the way, I'm not an MD. I'm a patient, but was a professor of anatomy. So if the tumor is on the surface of the gland near the edge and grows out, it will get into the neural tissue. And we're talking about the tumor itself, not traveling along the nerves, but simply poking through the surface. It's irrelevant in terms of primary treatment, because if that is a situation, the doctors have a responsibility if they're doing surgery, not to save the nerves, but to try to save the patient's life, which means they don't want to cut through the tumor. They want to cut around the tumor, which means they're going to cut through the nerves, and you're going to end up with erectile dysfunction. And that's its relevance. But I think what you really need to know, and I'd be happy to talk with you individually if you want, but I had perineural invasion. I was diagnosed about 24 years ago. I'm still here. So alone, it's not necessarily diagnostic. It has to be taken into consideration with what the burden is in terms of how many cores are positive, what the Gleason score was, what was the lowest PSA, et cetera. And you see my name there. You put a period between my first and last name, and you put an @ sign and write ubc.ca. Contact me, and I'll be happy to discuss with you if you'd like.
Oh, thank you. Because the pathology report doesn't say whether that invasion is outside, is the part that went slightly outside, or whether it's just inside. But I'm gathering from you it runs along the outside. So.
I can translate path reports.
Okay, thank you so kindly.
In English, but again, it's not a single feature. It does say that there was a tumor near the edge that was poking through.
All right. Thank you. Sorry to deviate there, but
Oh,
thank you.
No problem.
Thank you. Good question. Thank you, Richard and Frank.
I'll just let you get back to work there, Evan, to do this unbelievable kind of research that you're doing.
Thank you very much.
So on behalf of all of you guys, I want to say thank you for this presentation today. Is very revealing. This is not something that you can do with your eyes closed. This is quite difficult, very difficult. So thank you for your contribution.
No worries. Thank you very much for having me, and everyone have a great day. Thanks.
Thank you.
Thank you. Thank you very much.